action to achieve adequate clearance. Failure to do so will result in an unacceptable local recurrence rate and the potential for malignant transformation. So in phalloid tumor, we set benign to malignant. So we do excision with safety margin. If large, we'll do mastectomy. Okay, and I have to do safety margin to avoid recurrence because cell of nature are potentially malignant. Then we will go for hamartoma. Hamartoma is rare, not common, and presents as well circumscribed mobile lesion. Okay, Dr. Hani, after the slide, we'll take rest and we will uh, receive your question. They are often impalpable and may be accidentally discovered or discovered during screening mammography. These lesions usually impalpable, and as we said, the screening mammography, we can find lesion. Breast hamartoma, one of the few breast abnormalities that have characteristic features that allow sure or confident diagnosis without needle biopsy or surgical excision, and we will see the mammography of hamartoma. Management: lesion best left alone, or as we said in surgery, keep in peace. Here we can see the mammography of hamartoma. As we said, it's characteristic and no need for biopsy. As characteristic appearance of breast hamartoma appear as well-defined mass containing area of soft tissue and fat. Soft tissue and fat. So mass containing area of soft tissue and fat, so-called breast within a breast appearance, and this hamartoma after excision. Okay, now we'll go for cyst. We'll take 5 minutes as a rest. Then we'll go for breast cyst. Thank you. السلام عليكم. دكتور هاني، اتفضل اكتب سؤالك. هنخلص المحاضرة إن شاء الله. احنا قربنا نخلص وهنجاوب على كل الأسئلة اللي هتتكتب إن شاء الله في نهاية المحاضرة. ولو عندك استفسار تاني بعد ما نجاوب السؤال اكتبه، وهنرد على كل الأسئلة عشان ما نعملش انتربشن. أي سؤال، أي واحد عنده أي سؤال أيا كان السؤال يكتبه واحنا هنرد عليه إن شاء الله. Now we'll go to speak about breast cyst. Breast cyst is common girl around the age of 50, girl in the fifth and sixth decades, speak incidence around age of 50. It's assumed that the etiology is related to a change in the overall hormonal profile of the patient. دكتور هاني، انا شايف والله، اتفضل حضرتك اكتب سؤالك واحنا هنخلص ان شاء الله المحاضره ونفتح اوبن ديسكشن، هنرد على كل الاسئله ان شاء الله. Okay, as we said, cysts occur around the age of 50, and they assumed change in hormonal profile. Cyst can be single, can be multiple, can be symptomatic, or can be detected during screening mammography. What the patient complain in breast cyst? Cyst may appear suddenly and can grow to any size. May be painful and tender if infection occur. As we said, may be single or multiple, can be unilateral, can be bilateral. In general, cyst painless swelling, but under infection can become painful and tender. The cyst in examination appear as well circumscribed mobile lesion, and if the cyst superficial in breast, it will be fluctuant or with fluctuation. Or cyst may be much firmer if they are dense. In mammography, cyst appear as well-defined soft tissue density. As we can see here, this is the mammography of cyst. This is the cyst عند الأسهم السوداء كده. تمام. Cyst well-defined soft tissue density. This is the density or the cyst with halo sign. What is the halo sign? Described as complete or partial radiolucent ring surrounding the periphery of breast mass, as we can see here. The edge of the cyst may be partially obscured by surrounding breast tissue, as we can see in this diagram. This is the breast cyst here. We can found during mammography or patient complain with firm or mobile swelling. Then we will go ductictesia. Ductictesia is a benign condition. The problem in ductictesia is loss of elastin within the wall of the duct. and associated with chronic inflammation and chronic inflammatory cell infiltrate. This lead to dilatation and shortening of the duct. So, ductictasia is dilatation and shortening of the duct due to loss of elastin from the wall of the duct and the chronic inflammatory cells. So this patient will come to you presented with nipple discharge. This nipple discharge may arise from one or multiple duct. Okay. What is discharge? This discharge will be steady discharge. Okay. And there may be an associated lump representing dilated duct, and the nipple will be or may be retracted. Slit-like nipple retraction may be present, and this is a late feature. This is a late feature. So the patient main complaint is nipple discharge, as we see here in the signs of bacteria. Pressure on the areola will demonstrate discharge that's usually cheesy and may be palpable dilated duct associated with nipple retraction. We'll go for imaging in mammography. Mammography, most of patient or majority of patient with ductictasia have no diagnostic mammographic features. So, or not diagnosed, and the mammograph will be normal. Here's a ultra sound. We can see this normal duct, this dilated duct, as we told, ductictasia, duct dilated and become shorter due to loss of elastin and chronic inflammation. So this is the normal duct. Here we can see normal duct, and this is dilated duct. So in ultrasound, ductictasia can be seen as multiple tubular structure arising from the nipple. The significance of such finding is unclear. So, as we told, significant sign or the most important sign of ductictasia is nipple discharge. And if appear in ultrasound, okay. So, we'll go for management. We have a patient with cheesy nipple discharge, did ultrasound, we found dilated short duct, we confirm diagnosis. After confirmed diagnosis, majority of patients can be reassured from the patient you have short dilated duct and this discharge due to 1, 2, 3, 4. The problem to reassure the patient. But the patient told you, no, doctor, I have excessive discharge. It's affect my quality of life and start to have some problem or problem with discharge. Will do total duct excision, and the nipple should be everted as a part of this procedure. Now we will go to the ductal mastitis. Ductal mastitis is a chronic inflammation of the breast with dilatation of the mammary duct and plasma cell infiltration and abscess formation. The cause of preductal mastitis unknown cause, but this patient complain of tender, hot, red breast, discharge from the nipple may be bloody or non-bloody. We can palpate and feel the lump behind the nipple, and the nipple become pulled in. Occasionally, a collection of pus abscess or an abnormal connection between duct and the skin, the fistula. Okay, this is what mean most common risk factor, or we can found in this patient is abscess and fistula formation. As we can see here, this is a preductal mastitis, tender swelling. Most cases of preductal mastitis will be treated with antibiotic, and some people will be self-limiting disease. No need any treatment, and you will advise the patient go to your GP or come to the clinic if your symptoms return, or if you have any new symptoms, you can come. If we have abscess or fistula, we'll do surgical excision. Here, the mammary duct fistula, as we can see here, mammary duct fistula is a communication between subaerial duct and skin. Fistula, in general, definition is connection between two surfaces. One here is the skin and subaerial duct. It's usually occur in periareal region. It often occurs spontaneously following underlying preductal mastitis, but most common cause preductal mastitis, but also can occur following incision and drainage of non-lactating breast abscess. It's common in younger female, and most common risk factor is smoking. Also, in general, complication of abscess fistula, abscess anywhere. Sometimes, like perianal abscess after incision and drainage, patient come with fistula. So it's common complication after abscess drainage. Now we will go for duct papilloma. Duct papilloma, peak age between 35 to 55 years. Finger-like papillary tumor formed from ductal epithelium around the fibrovascular core. So it's called papilloma due to finger-like papillary tumor or projection formed from ductal epithelium. It's common found in major duct, may be solitary, single, or multiple. Intraductal papilloma, two types: solitary central papilloma, peripheral multiple papilloma, what's papillomatosis, and we told peripheral papilloma should be differentiated from carcinoma. As we told, usually present with single duct bloody nipple discharge, but we can feel a mass in large obstructing papilloma, where we can feel the mass retroareolar mass. What about the risk factor? Till now, no known risk factors for developed ductal papilloma, and the malignant potential or transfer to malignancy is related to the presence of atypical hyperplasia, usually more with peripheral and multiple type. Then imaging and investigation for patient. We have patient who felt a mass, retroareolar mass, and bloody nipple discharge. It's usually by mammography. If confirmed diagnosis, we'll do excision through circumillular incision. Before we'll go management, okay, and we can do dactography to detect the papilloma. The management is usually by excision through circumillular incision after cannulation of the affected duct and injection of methylene blue to delineate the affected duct. Now we'll go for a very important slide, breast hematoma. Breast hematoma can occur secondary to surgical intervention, including fine needle or biopsy, excisional biopsy, or the most common cause is inadequate hemostasis during procedure. So post-operative, patients start to complain hematoma. Or after minor trauma to the breast, patient can complain breast hematoma. So breast hematoma, most common cause post-operative hematoma is inadequate hemostasis. Can occur also after minor trauma to the breast with patient presented with tender mass and the overlying skin will show bruises in early phase following injury. So patient now with hematoma, what we will do with this patient post-operative hematoma that enlarged should be evacuated under anesthesia and analgesic. Now patient complain of hematoma, doctor, I have tender swelling, decrease in size. So we'll do surgical evacuation under anesthesia. Then we can control the pain by analgesic. But if hematoma not increase in size and liquefy, it can administrated by fluctuation. Aspiration may provide some relief, but recurrence is high with aspiration. Short-term clinical follow-up to ensure resolution of symptoms may be necessary. As we can see here, breast hematoma. The image shows breast hematoma. Management depend on presentation of the patient. In case of large hematoma or increase in size, we will do evacuation. Okay, if liquefied, we'll do follow up. Patient start to complain of tenderness, we can do aspiration, but aspiration carry risk of recurrence. Then we have important slide also, fat necrosis of the breast. About 35 to 40% of patients presented with fat necrosis of the breast have a history of trauma. The problem of fat necrosis can be mimic breast carcinoma. It's a problem of fat necrosis. So surgical trauma secondary to biopsy or plastic surgical procedure in the breast or injection of silicone or narcotics into the breast can cause fat necrosis. Management. Our experience, unequivocal diagnosis of fat necrosis can be made by biopsy. So diagnosis by biopsy. Can do observation and the resolution of palpable mass. In the absence of firm diagnosis, open excisional biopsy is recommended to differentiate between fat necrosis and carcinoma. Biopsy, full stop. We did many patients with breast mass and histopathology report, necrosis, fat necrosis, fat necrosis. So if in doubt, biopsy. If in doubt, biopsy. Don't put yourself, don't put your patient under stress. Don't uh, make misdiagnosis. I will see next visit to the patient. Mass will decrease. Mostly fat necrosis. No, if not sure, biopsy in general breast and fat necrosis. To differentiate between carcinoma and fat necrosis, biopsy. This is a patient, okay, after breast conservative surgery, as we told, after plastic surgery or injection of silicone. Patient presented with a lump or mass, and this is after excision, which reveal fat necrosis of the breast. Then we have radial scar. Radial scar often detected during screening mammography or found accidentally in excision during excision of breast biopsy for another pathology. So it is detected. Patient will not complain of scar. Patient complain mass will go to do excision for this mass who found scar. So found accidentally or during mammography. What is the surgical importance or the problem of this scar? This scar may mimic carcinoma. So if any lesion mimic carcinoma, we have to remove to sure diagnosis. So surgical excision by mammographic localization of the lesion is recommended to exclude any underlying carcinoma. There is no clear evidence for increased risk of breast cancer in patients who have been treated for radial scar. As we can see here, this is mammography. Okay, this is the scar here after excision. This is the mammography and after excision. Then we have rare benign disorder of the breast. First, the granular cell tumor. This tumor or lesion is rare, but surgical importance, it can stimulate carcinoma. Can stimulate carcinoma. The patient will come to you complaining of breast mass. This mass is fixed to skin or underlying muscle. Then we have granulomatous lesion of the breast. This lesions of the breast are also rare. They can be secondary to systemic condition as sarcoidosis or infection as TB or fungal infection or reaction to foreign material as silicone and narcotic injection. Now we'll go for Mondel disease of the breast is also rare superficial thrombophlebitis of the lateral thoracic or superior thoracodorsal thoracoepigastric vein. So Mondel disease, as we can see here, I think is better. This thrombophlebitis or superficial thrombophlebitis of the lateral thoracic or superior thoracoepigastric vein. Now we'll go for gynecomastia. Speak about we finish benign disorder of the breast. Go for another disease. This gynecomastia. Gynecomastia mean as a benign proliferation of glandular breast tissue in men. May be physiological and it's common in newborn, adolescent, and older men. Self-limiting disease, but can also treat it to minimize emotional stress and physical discomfort, and may be non-physiological. So physiological, and this is a common, and may be non-physiological, caused by chronic condition as liver cirrhosis, renal insufficiency, hypogonadism, or use of medication, supplement, and sterility caused by tumor. To treat gynecomastia, we have to treat the cause. So we have to stop use of contributing medication. It is the main step in management of gynecomastia. Medications such as estrogen receptor modulator and surgery have role in treating gynecomastia in selected patient, and this treatment should be early and should be directed by the patient. Now we finish our benign disease. We'll take rest for 5 minutes. Then we'll go for effect of breast cancer on the public health, and this will be the introduction for breast cancer lecture tomorrow, inshallah. But today we'll speak about effect of cancer on public health. Only 5 minutes, then we'll go. We have about 20 minutes to finish. If anyone had any question, you can write in chat, and after finish, we will answer all questions. Okay, thank you. دكتور هاني، اتفضل اكتب سؤالك. دكتور هاني كامل، اتفضل اكتب سؤالك واحنا هنرد عليه ان شاء الله في اخر المحاضره ان شاء الله.
السلام عليكم دكتور هاني. ممكن انا فتحت لك المايك، ممكن تتكلم وتتناقش مع دكتور جمال براحتك يعني. دكتور هاني. دكتور هاني.
اوكي دكتور احمد رشاد، احنا هنكمل، ولو في اي استفسار حابب يتواصل معايا على الخاص ماشي. بعد المحاضرة لو في امكانية ان احنا نوصل له ماشي، مفيش مشكلة. تمام
ماشي ماشي خلاص كمل يا ريس كمل.
ماشي. Now I have a question in private. Gynecomastia should be investigated. Yes, should be investigated. Because the patient will complain I have different size of breast, so she will be investigate, no problem. About the ectasia by ultrasound, not mammography. Yes, we know by ultrasound, not mammography. Okay, but the problem of ultrasound is operator dependent. Okay. Fat necrosis can be seen by mammography and MRI. Yes, can be seen by mammography and MRI, but sure diagnosis, biopsy. Sure diagnosis, biopsy. Okay, this is the question I answered in private, and I will tell the question. Now we'll go for importance of breast or of cancer, public health. Cancer have many issues associated with its significant or have significant impact on public health at multiple level. Okay, the years of life is lost due to premature death, and also the economic load due to loss of productivity and cost associated with illness and therapy, and the long-term effect of cancer and its treatment on the quality of life of survival take a national toll. So cancer will affect the public health. Also, cancer will affect individual patient and their families in different ways. And we have all National Cancer Institute have a study about this. Its impact on large population can provide important information about the practice, the policies, and the program directly affected the health of millions of people. They need to improve the health. They need to improve the quality of life, and cancer, one of the diseases that affect this quality of life and cause problem to the economic load. As we told, NCI, the National Cancer Institute, funded research has contributed to major improvement in public health and cancer control. The future of cancer public health research, what is the importance or what is the goals of this research? The goal of public health research is to generate a knowledge about how to monitor, okay, how to avoid, how to treat. So they monitor and they change individual and collective behavior to ensure the knowledge, and how to transfer it to practice and policies to start to monitor and treat the patient and to control the cancer and population health and survival shape research will continue to reduce cancer risk incidence and mortality and improve the life of cancer survivor and general population. The vision of this research is that all population groups will be benefit equally from advances in cancer research. So they will do this through the researches, and this will continue to grow as major public health issue in the world as population age, and there's more researches done across the spectrum of cancer, from prevention, detection, diagnosis, to treat and to improve quality of life. And this is important and essential to develop public health intervention to reduce the risk of cancer, support research to reduce cancer disparities, ensure that cancer survival has highest possible quality of life. As we said, cancer affect the people. We have to know more information about the disease to avoid. Now we finish our lecture today. If anyone had any questions, you can send or ask. Dr. Hani can 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 ask, send me at any time, private, no problem. If anyone had question and want to prepare for tomorrow, no problem, we can answer all questions. Tomorrow, inshallah, we'll speak about breast cancer, about the diagnosis, about the different ways of management, inshallah. Okay, thank you. Now, Dr. Ahmed Rashid, I finished my lecture today. Tomorrow, inshallah, will be at the same time. Assalamu alaikum.
السلام عليكم. شكرا دكتور جمال على المحاضرة القيمة دي. شباب، حد عنده أي أسئلة أو أي استفسار؟ اي استفسار يا جماعه؟ عنده اي حد عنده اي اسئله؟ طيب طيب ان شاء الله بنكمل اليوم الثالث بكره باذن الله في نفس الموعد، الساعه 1 للساعه 3 الظهر، وان شاء الله الشهادات برضه هتكون جاهزه في خلال يومين او ثلاثه، والساعات بتاخد اسبوع كده ولا حاجه باذن الله. نشوفكم على خير باذن الله بكره.